Our lecture today is about cataract, but we will give you short notes about the crystalline lens. Crystalline lens is a biconvex avascular transparent structure. So it is transparent because it is avascular. It is enclosed by capsule that cover all the areas of the lens. The central structure here through this cross section of the lens is the nucleus. The nucleus is the central compacted core, which represent the old lens fibers, while the cortex, which is the area surrounding the nucleus, represent the new lens fibers, which surround the nucleus. As we said, the nucleus are the old lens fibers formed during intrauterine life, while the cortex laid down later on, so they are the new lens fibers. The capsule, which is the thickest basement membrane in the body, and represent the structure surrounding the lens, in addition to its attachment to the zonules at the periphery or the equator of the lens. The capsule is responsible for molding the lens substance during the process of accommodation. The process of accommodation required this elasticity of the capsule, required the integrity of the zonules and the contraction of the ciliary body. So it is a process made up by these three elements. One of the symptoms and signs of diseases of the lens is cataract. Cataract ends with painless impairment of visual acuity. The normal crystalline lens is transparent. Any opacity within the lens, whether it is congenital or acquired, results in cataract. Some people with cataract has good vision, so not necessarily every patient with cataract must have poor vision, because we have stages of cataract. Another sign or symptom of lens disease is presbyopia. Presbyopia means decrease in accommodation that occurs normally after 40 years of age. As we said, accommodation is a complex process that needs integrity of the capsule and the zonules and contraction of the ciliary body. When any pathology occurring to any of these structure, or weakness or sclerosis that occurs with the age, result in presbyopia. Now we come to the classification of cataract. We can classify cataract according to its site within the lens, or to the degree of maturation, or to the onset. What we mean by the site within the lens? I mean the position of cataract within the crystalline lens. As we saw in the previous image, cross-sectional image of the crystalline lens, we divide it into cortical nuclear region and capsular region. So that's what we mean by according to its site within the lens. We mean these parts. What about the maturation? The density of the opacity according to its onset. It's either acquired or congenital. The classification of cataract according to its site within the lens. It's either posterior subcapsular, anterior subcapsular, cortical, or nuclear. Posterior subcapsular, this means that the opacity is just anterior to the posterior capsule. Anterior subcapsular, the opacity is just posterior to the anterior capsule. You can imagine this, I suppose. Cortical cataract means that the opacity involving the cortex. Nuclear cataract, the opacity involves the nucleus. Cataract can be detected by slit lamp examination. During slit lamp examination, some types of cataract we need just to use diffuse illumination to identify it, like cortical cataract, or parallel pipe section, like nuclear and posterior subcapsular cataract. Direct ophthalmoscope also is a useful measure whenever there is no slit lamp. Usually in direct ophthalmoscope when we direct the light through the pupil, we will have the red reflex, which is the normal accepted view. If this red reflex is absent partially or completely, that means there are some opacity in the media that could be cataract. B-scan is the type of ultrasonography we use it to examine the eye. Also can be used sometimes to give an idea about the opacity of the lens. The first image is a slit lamp image during a lateral parallel piped section where the light is directed laterally, coming from the cornea through the anterior chamber and then giving us a section of the crystalline lens. Here the crystalline lens is with nuclear cataract. What we mean by nuclear cataract, that the nucleus is opacified. The degree of opacity can be mild, moderate, or severe. Here we can see it's a brown discoloration of the nucleus, which is from moderate to severe type of nuclear cataract. The adjacent image shows a mild type of nuclear cataract. Also, you can see the opacity is in the center of the crystalline lens. The type of imaging on a slit lamp we use to obtain this classification here is parallel section, lateral parallel section. In the first image, we are using diffuse illumination. Through a dilated pupil, we can see this type of lens opacity, which is wedge-like extensions. This type of cataract is cortical cataract. In cortical cataract, we don't need parallel pipe section. The adjacent image will show us another section through the cornea, anterior chamber, and then through the crystalline lens. We can see here that the location of the opacity at the posterior cortex and posterior capsule. This is posterior subcapsular cataract. The second classification of cataract is according to the degree of maturation of this lens opacity. So we can classify it either into immature, mature, or hypermature cataract, intumescent cataract, and Morgagnian cataract. Immature cataract, where part only of the lens, any part actually, is the opacified and other parts are transparent. Mature cataract, complete opacification of the lens. Hypermature cataract, in which it is a type of mature cataract where there is liquefaction and leakage of fluid from the lens toward the aqueous humor. So the content of the lens is now shrinked, smaller. This will result in shrinkage of the lens capsule and folding. On examination, we can see shrinked capsule, smaller size of the lens. This is a type of hypermature cataract in which fluid leaves the lens into the aqueous humor. The opposite happens in intumescent cataract. Intumescent cataract comes with another name, which is phacomorphic cataract. This is either mature or immature cataract, but the thing here is that the fluid from the aqueous humor will influx inside the lens, causing lens swelling. The lens will enlarge, pushing the periphery of the iris toward the cornea, occluding the angle of the anterior chamber and resulting in type of glaucoma, which is emergency, and we call it intumescent glaucoma. Morgagnian cataract is another type of hypermature cataract. So the hypermature cataract, where there is a shrinked capsule and a liquefied cortex, can develop into a Morgagnian cataract. What is Morgagnian cataract? The total liquefaction of cortex happens in this hypermature cataract and is followed by sinking of the nucleus inferiorly. This image will give you a complete description of all the types I just spoken about. The normal crystalline lens is just a clear lens. Immature lens, only part of the lens is opacified. Mature lens, all the lens is opacified. Hypermature, you can see it's a shrinked and a smaller in size lens which lost its content almost. Nuclear cataract, the central nucleus is involved, posterior subcapsular, and of course cortical here is missing. Morgagian cataract, you see that the nucleus is sunken inferiorly. This is a type of hypermature cataract. The intraocular lens, this is the lens that we use after removing the cataract during cataract surgery. According to its onset, it's either an acquired cataract or congenital. Now we will discuss the acquired cataract and then we will see the congenital cataract. Acquired cataract, it's a type of cataract that occurred during development. Actually, the child is not born with cataract. That's what we mean with acquired cataract. It's either age-related or presenile or traumatic, drug-induced, or secondary cataract. These are the types of acquired cataracts. Very, very important subject. Age-related cataract after 50 or 60 years old, a type of acquired cataract will happen in almost most people. What we mean by presenile cataract, this develops before the age of 60 in certain conditions, in diabetes mellitus, in myotonic dystrophy, atopic dermatitis, and neurofibromatosis type 2. What is the percentage of cataract in each of these conditions is important. Myotonic dystrophy, almost all patients will develop this type of cataract. Atopic dermatitis, only in 10% of patients. What about traumatic cataract? This is the most common cause of unilateral cataract in young individuals. Any patient with unilateral cataract, you should ask first about any history of trauma. This trauma can be in this week, in the previous month, or before 5 years. Drug-induced cataract and secondary cataract are also an important causes of acquired cataract. Drug-induced cataract mostly related to steroid. And secondary cataract is a cataract that occurs due to an intraocular pathology. It's not like the presenile cataract where there is systemic pathology. Secondary cataract occurs due to intraocular pathology. Traumatic cataract is the most common cause of unilateral cataract in young individuals. So what are the mechanisms of traumatic cataracts? Either direct penetrating injury to the lens, it's either a concussion or blunt trauma, could be due to electrical shock or ionizing radiation, or even infrared radiation, which is part of the rays of the sun. This picture will show you a type of traumatic cataract that occur after blunt trauma, concussion. This is roseate cataract. You see the shape of the opacity is just like a flower. That's why we call it a roseate cataract. It's very important type of cataract you need to know. As we said, secondary cataract occur due to an intraocular pathology, so it is a type of complicated or secondary cataract. What are the causes of secondary cataract? Chronic anterior uveitis are the most common. This is the most common cause of secondary cataract. Usually patient with a chronic anterior uveitis ends up with cataract. Acute congestive angle closure glaucoma. After attack of acute congestive angle closure glaucoma, the patient will develop multiple foci of cataract, especially in the anterior cortex due to ischemia. High pathological myopia. Patients with high pathological myopia are more prone to develop a secondary type of cataract. What about hereditary fundus dystrophy? These are type of genetic retinal disorders that are patients born with or develop later during life, such as retinitis pigmentosa. These also causes of secondary cataract. What is the treatment of cataract? You know, there are no method for treating cataract. There are no medical treatment for cataract other than correcting the refractive error with the glasses. And when this is not possible anymore because the cataract is very dense now and occluding the entire visual axis and the patient is not benefiting from any spectacle correction, we go for surgery. What are the indications of surgery? We don't operate on any patient with cataract, but there are certain indications you need to know. Visual improvement. When the patient asks you to improve his vision or her vision, when the patient asks for surgery, this is the most important indication and the most common indication. Whether the cataract is mature or immature, when the patient feels that his vision is not enough to perform daily requirement, surgery is indicated. What are the medical indications? Are intumescent cataract, as we said, when the cataract is swollen and occluding the angle and causing elevation in intraocular pressure and glaucoma. This is an indication for surgery. Other example of medical indication is when the lens is opacified to a degree that you can't see the retina. You can't examine the retina, you can't examine the optic disc. So in these patients, especially in diabetic patients, it is necessary to examine the retina, to give a treatment to the retina according to your examination. So this is a medical indication. Cosmetic indication, sometimes, as you know, the cataract, when it is opacified, will give a shiny white color to the pupil, and this is cosmetically unacceptable as in certain situations, so it might be an indication. The most important one, as we said, are the visual improvement and the medical indication when you advise the patient to remove his cataract so that you can either protect the eye from glaucoma or examine the fundus. Anesthesia used is either general and pediatric or in mentally retarded. Either local, we use local injection, or topical drops, or intracameral. Intracameral is referred to injection of local anesthetic inside the anterior chamber of the eye. We can choose either of these methods according to the surgeon experience and patient preference and medical condition. We explained to you the causes of acquired cataract. Now we come to the congenital cataract, where the child born with cataract or develop in the first months of life. This is a type of congenital cataract. It's a very important subject. 2/3 of the cases are bilateral, 1/3 are unilateral. Whenever the condition is unilateral, you might think it is a hereditary, possibly, but if it is bilateral, you might think more likely it could be metabolic disorder or infection. Anyhow, this is not a very clear cutoff, but let's come to the causes of congenital cataract. It's either isolated hereditary cataract. What we mean with that? What we mean with isolated? Isolated means that the child or the subject, let's say, has only cataract. They are systemically fine and normal, healthy individuals, but they have some sort of hereditary cataract that runs through their family line. This occurs in 25% of cases, usually autosomal dominant. Other modes of inheritance are possible. Metabolic cataract. We said the first cause is isolated hereditary cataract. Metabolic cataract that can be associated with certain metabolic disorders like galactosemia and Lewy syndrome. What about prenatal infection? Prenatal infection, which is literally the torch infection, are important cause of cataract. Almost all the elements of torch infection can result in type of congenital cataract. So you need to screen the child, screen his family members for the hereditary type of cataract, check for any chromosomal abnormality like in Down syndrome, and ask about any exposure to suspect prenatal infection, and we do a blood test, blood workout for prenatal infection, the torch infection. And if we suspect metabolic disorder, we need to send for pediatrician. Congenital cataract, as we know, is a type of one of the causes of leukocoria. Leukocoria is a white pupil One of the differential diagnoses of it is congenital cataract. In the first image, this is bilateral leukocoria, and the second image is unilateral leukocoria. Treatment of congenital cataract depends on the density of cataract, and we can assess the density of cataract through visualization of the retina. If the cataract is so dense we cannot see any detail of the retina, so surgery in this case is urgently indicated. So what we mean by urgent, within 1 week or 2 weeks. Surgery has many steps. In congenital cataract we have an additional steps added to the cataract removal in adult patient. Let's start with the usual steps, which is anterior capsulorhexis, then aspiration of lens matter. Anterior capsulorhexis is a creation of opening, which is round opening in the anterior lens capsule to reach the lens matter, which is then aspirated. By far these are the 2 steps required to remove cataract in adult patient. Then we implant the intraocular lens and replace the intraocular fluid and end the surgery. But in pediatric age group we add additional 2 steps, which are posterior capsulorhexis and anterior vitrectomy. We mean by posterior capsulorhexis is the creation of another circular opening in the posterior lens capsule in order to reach the anterior vitreous to remove it by anterior vitrectomy. Anterior vitrectomy is removal of the anterior surface of the vitreous, which is just posterior to the lens capsule. In all pediatric age group we should do these additional 2 steps. In the first years of life, removal of cataract from a child is not followed by intraocular lens implantation like in adult cataract. In adult cataract we implant lens always, unless there are some contraindication, but in pediatric age group, especially in the first 2 years of life, we don't implant intraocular lens. We leave the child aphakic in that eye. Now we come to the second most important step. We finish the surgery. After the surgery we don't just leave the patient. The child needs to establish normal visual pathway and normal vision through the correction of aphakia in that operated eye for congenital cataract. Aphakia mean absence of crystalline lens. After removal of congenital cataract, the eye is now aphakic. In unilateral aphakia, when we operate on unilateral congenital cataract, we can correct this aphakia either with intraocular lens if the child is of adequate age, which is more than 2 years, or with contact lens. We don't use glasses, but in bilateral aphakia we can use glasses or intraocular lens if the child is of adequate age. And this is the note here, when the child is of adequate age we can implant intraocular lens. So this is very important. You need to know at least what are the additional steps in pediatric surgery and what is the meaning of unilateral aphakia and bilateral aphakia. Aphakia, it's either congenital or acquired. Acquired, like an example after cataract surgery, is the absence of lens from the eye or from the pupillary area. Aphakic eye is a strongly hypermetropic eye. This means aphakic eye has high degree of hypermetropia. Treatment of aphakia depends on whether 1 eye or 2 eyes involved. The main treatment is to correct the resulting refractive error, which is high hypermetropia. Hypermetropia is a type of refractive error where the parallel rays of light entering the eye is brought to a focus behind the retina. This means it's a virtual focus, and it's usually corrected by convex lenses or plus lenses. Usually the first line of treatment in bilateral aphakia is high-powered convex lenses, spectacle glasses. High-powered spectacle lenses usually cause magnification of image on the retina by about 30%, which will produce then what we call it anisoconia. We usually use glasses with high-power convex lenses only for bilateral aphakia for this reason. In patients with unilateral aphakia, we cannot correct one eye with the glasses and leave the other eye without the same correction, because these glasses, the convex lenses, will produce a magnification of the image of that eye on the retina by about 30%, and both retina will not be able to fuse these unequal sized images. The images from the two eyes now will not fuse in the brain, and this will present as anisoconia, which is diplopia. So patients with bilateral aphakia, we can correct them with high power convex lenses as a spectacle. Spectacle mean نظارات. But in unilateral aphakia, we can never use spectacles because of this anisoconia. Normal eye send normal size image, while aphakic eye now with high power spectacle produced large image by 30% the actual size. So the cerebral cortex now will not fuse these two images because of the difference in size. This results in diplopia or anisoconia. Contact lenses are a very nice option because contact lens will produce only 1% magnification in image size, not like the glasses will produce 30% magnification. So in unilateral aphakia, we can use contact lenses. Intraocular lens is the best option, and there are no any degree of magnification of image with intraocular lens implantation, and we can use it for either unilateral or bilateral aphakia, but the child condition and eye and age should be proper. What is ectopia lentis? Ectopia lentis mean displacement of the lens from its normal position, which is the pupillary axis. So absence of the lens from the pupillary axis is aphakia or loxated eye, while ectopia lentis is displacement of the lens from its normal position. This displacement is either complete displacement or partial displacement, and it's either acquired or congenital. Acquired causes of ectopia lentis is trauma, obviously. Strong hit to the eye will result in dislocated lens. Enlarged eye, like in high myopia or ophthalmos. The eye is large enough. Ophthalmos is some manifestation of congenital glaucoma. Due to high intraocular pressure, the eye will stretch and enlarge, and the cornea will enlarge. Why large eye associated with ectopia lentis? There will be stretching of the zonules due to increased diameter of the eye, and this will cause distraction in the zonule. The zonule hold the lens in position, and this will end up with ectopia lentis. Anterior uveal tumor and hypermature cataract also might be associated with ectopia lentis. Congenital causes of ectopia lentis, you might have an idea about them. It's either autosomal dominant or autosomal recessive. Associated with aneuridia. Aneuridia means absence of the iris. In this type of congenital ectopia lentis, usually there is no systemic association. When there is systemic association, we have an idea about Marfan syndrome, Walmer-Chersany syndrome, and Ehlers-Danlos syndrome, even homocystinuria. These are systemic disorders associated with ectopia lentis. It's very common in society. Marfan syndrome, homocystinuria are very common. This image refers to ectopia lentis. We see the first image in Marfan syndrome, where the edge of the dislocated natural lens. Of course, here the lens is also opacified, cataractus, and we see the edge of the lens. In normal condition, we should not be able to see the edge of the lens through undilated small pupil. So here we can see that the lens is located superior-temporally. The adjacent image will show also almost superior dislocation of the lens. We see the edge of the crystalline lens, and these are the stretched zonules. When lens move inside the eye from its normal anatomical position, this will cause number of complications. These complications are very important: refractive error, glaucoma, endothelial touch, and lens-induced uveitis. Refractive error is either myopia or astigmatism. If the lens is tilted, this will result in astigmatism. If the lens moves forward, this will result in myopia. If the lens is absent from the pupillary axis, almost absent, this will result in hyperopia. Glaucoma, when the lens causes pupillary block. This means the lens blocks the pupil, occludes the pupil, moves forward and then occludes the pupil. This will result in glaucoma. Endothelial touch, when the lens is shifted into the anterior chamber and become in contact with the endothelium of the cornea. This will result in endothelial touch. Of course, this is an emergency here because it will damage the cornea. Lens-induced uveitis, of course the lens will move inside the eye, and this will cause irritation and inflammation of the ciliary body and the iris, and resulting in uveitis. We mentioned the complication of ectopia lentis, and these complications are the usual indication for treatment, which is a refractive error, usually corrected by spectacle or contact lens or surgery if we cannot correct them by spectacle. Glaucoma is another indication for treatment. Okay, and endothelial touch, lens-induced uveitis. For glaucoma, if the lens is clear, we can try doing an opening, laser made opening in the peripheral iris. We call it YAG, laser iridotomy. Iridotomy means we create an opening in the peripheral iris using laser machine. This will abort some types of pupillary block glaucoma and might elevate the condition. But if the lens is cataractus, we do lens extraction. Of course, the indication of a treatment means indication to do something, which is either spectacle, either laser iridotomy, either lens extraction. This doesn't define the type of a treatment you do, but the indication for treatment. So that's all you need to know: when to intervene, when there is refractive error, when there is glaucoma, endothelial touch, or uveitis induced by the lens. About the type of intervention, this is related to us as ophthalmologists. It's either spectacles, either cataract surgery, or it's either lens extraction. If there is no cataract, it's either laser iridotomy, and so on.